Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging at Memorial Sloan Kettering Cancer Center, and I'm also Vice Chair of Education, and I'm a Professor of Radiology at Cornell Medical College in New York. What imaging modalities are used in staging mesothelioma? CT, ideally with intravenous contrast, is the primary modality for identifying and evaluating patients with malignant pleural mesothelioma. And what we primarily see in these patients is a unilateral effusion in more than 70% of cases. We see pleural thickening in the majority. Over 90% will have some pleural thickening. And that pleural thickening may be nodular, lobular, circumferential, or certainly if it's greater than a centimeter in thickness, it's particularly concerning for mesothelioma. Other things we look for in imaging include ipsilateral volume loss. So one lung will look smaller in volume. We look for invasion of the structures of the mediastinum, pericardium, the diaphragm, or the chest wall. These are all things that may make it unresectable and are used in staging. We also look for intrathoracic nodal involvement and for pulmonary and distant metastases. Most importantly is this local tumor extension through the chest wall, diaphragm, mediastinum, or spine. And again, that's a very hard area to be certain. What we look for is obscuration of the fat planes. If we lose the fat planes, that may suggest that there is invasion through these structures, but it's not very specific. Unless we see actual destruction of ribs, for example, we may not be certain that it's invading through the chest wall. So what do we do with CTs? Well, we look at the T stage, and we also look at the end stage. So T, the tumor, we want to quantify it as a T1, a T2, a T3, and T4. And between a T3 and a T4, it's actually quite difficult on CT. And MRI doesn't add much more to that. Because we're not great at evaluating this invasion of the mediastinal fat or the endothoracic fascia or the chest wall, unless you actually see destruction. And nodal stage, end disease, we could pick up enlarged lymph nodes. But again, that may not be very specific. And we do look in certain places where generally thoracic tumors may not go. In this case, for mesothelioma, it would include the internal mammary chain, superior diaphragmatic lymph nodes, or intercostal lymph nodes. So we will look at that with CT. But in these cases, PET-CT may be useful to point out these hypermetabolic lymph nodes, or if we see pleural thickening, is it actually avid on PET-CT? Now, as I mentioned, MRI can complement CT in some patients. Maybe you can better delineate the soft tissues, but it's not significantly better than CT. PET-CT, as I mentioned, is useful in the staging and extent of lymph node involvement. And it's also very useful for extrathoracic metastases, because generally we image the patient with the CT of the chest that goes through the upper abdomen, but not the entire body, which a PET-CT would do. And it also can be useful in differentiating if we have a pleural-based mass. Is it a malignant mesothelioma, or is it some benign pleural lesion? So if it's not FDG avid, then it probably can be a benign lesion. Beyond this, you may end up needing to do more invasive studies, which generally are done by thoracic surgeons, or such as endobronchial ultrasound or esophageal ultrasound, and maybe even surgical procedures such as mediastinoscopy to actually evaluate invasion into the mediastinum, and laparoscopy to evaluate invasion through the diaphragm. As I mentioned, those are tough areas to delineate on CT, because if the lesion really sits on the diaphragm, you may not be certain that is it actually just contiguous with the diaphragm, or is it invading through it? Same thing with the mediastinum. Is it just along the mediastinal pleura, or is it actually extending through? So those are areas that are difficult on CT, but can be evaluated, as I mentioned, in clear-cut cases. In the more subtle cases, it is more difficult.